pattern, signs and symptoms. Working on my legibility so people can read my writing. Recap, signs and symptoms of a flexion-based lumbar case.
Hurts to sit, can't bend, touch your toes,
Right,
sciatica.
hurts to sit, can't bend, tie shoes.
And I think the biggest one was just the sciatica symptoms.
Yep. Put on socks. Sciatica / disc. All right. So people with, just to recap, people with flexion-based problems mean they can't, flexion means bending forward. They can't do this movement because of pain, stiffness, sciatic pain, hamstring tension, which obviously makes bending, lifting, carrying, sitting, anything that involves, lumbar or lower back flexion-based movements. This is what we're talking about in terms of a flexion-based problems. Again, these are the signs and symptoms that someone is usually going to have a lumbar flexion-based problem. Okay, so now we're going to go into assessment. All right. What are we starting with? Standing toe touch.
Yeah, multi-segmental flexion.
Toe touch. Or multi-segmental flexion. Okay. All right. So we determine the person has pain or inability to touch toes. So what's the next test that we do?
So then from there we would do cat.
We're going to go to seated toe touch.
Oh, we're going to do that one next.
We're going to do that one first. Tim is right. That's the actual.
Okay, I see.
Right. Seated toe touch. I've skipped steps over the years.
Okay.
Because I just see the problem, but this is the correct way. We want to do a seated toe touch.
Okay.
Take out gravity, because if they can't touch toes in standing, but can touch toes in sitting, it means there's no mobility problems that are actually stopping them from doing so. It's just something with their gravitational, posterior weight shift, or just kind of strength and motor control.
Sure. Okay.
So in that case, doing a bunch of manual therapy just because
not gonna do shit.
It's not gonna move the needle.
Yeah, you'd almost teaching them how to hinge properly would probably be the go-to.
All right. Okay. The percentage of people that can do standing, that can't do standing but can do seated, is relatively small. But it's just a good habit to just check. It takes 5 seconds to check. I have to get back into better patterns, so seated toe touch is the second one.
Okay. All
right. From there,
and then we go lying leg raise next?
Yeah, we can go straight leg raise. Leg raise. All right, and what we're looking for: pain, neural tension tests.
Yeah, and then what did he say? The goal would be to ideally get to
70 degrees.
Yeah, that's what okay.
Passing. All right, so working on my legibility, guys. Hopefully that's better. So I think it's just a we want to. There's a hierarchical flow in SFMA that just makes sense. But I think just for patient comfortability and just kind of flow of assessment, going from they're on the table already doing a seated toe touch. It's easy to just have them lie supine and do a leg raise from there, and then they can go into quadruped.
Sure.
So what if we determine that they have 70 degrees on both sides, right? It's like, let's say they have a passing straight leg raise test. What do we look at next?
Lumbar flexion?
Yes.
Okay.
We could get into the weeds of with or without dorsiflexion, right? So put a little dorsiflexion in to crank a little bit more tension on the nerve. But I think if they're 70 degrees or close to 70 degrees bilaterally, the issue is not going to be like hamstring, like nerve glide type of thing. I've just never really seen that to be the issue, because for these people, I'd say with confidence, 95% of the times it's coming from the chain of tension, upper back, like lumbar, just having no tissue mobility has created the tension everywhere down below. So if we're just assessing the bottom length of the chain of tension, let me bring in the rope. All right, so again, chain of tension theory. This is if this is one long muscle that attaches head to toe. If the rope is long enough, I should be able to bend with ease, right? But if there's any restrictions or knots in the chain, how's my view in the camera?
You're good. I was just checking to make sure.
Right.
Man, those are some good knot tying abilities.
Thank you. Right. If anywhere along the chain from head to toe, if it's restricted, it's going to shorten the entire length of the chain. Right. So now when I try to bend forward, I just can't go. Right. The default thinking is that since people feel tightness in their hamstrings, to think I must stretch my hamstrings, but that the hamstrings are just this lower chain right here. So if you stretch out this entire chain, people feel it in the lower half, but there's no restrictions here. And it's already under too much tension. So that's why stretching hamstrings doesn't fix the issue, because you're creating more tension on the area that's under too much tension already. So we're looking for the knots. We're looking for the restrictions to release these. You release these restrictions, untie the knots. All right. Let's look at my knot untying abilities next. All right. So our assessment for, again, flexion-based problems is to just kind of pin down where these restrictions are. Right. And I'm saying the vast majority of times the restrictions are going to be in the upper back, shoulder, right? Sometimes in the lumbar area. Very rarely is it going to actually come from hamstring and nerve tension, right? For disc cases, yeah, we may see some pretty gnarly asymmetrical, straight leg raises. But the answer is to fix that is not to crank on their nerve, right? So even if they possess a straight leg raise, let's say 30 degrees up on the right and 70 degrees up on the left, the solution is not to force the leg to 70 degrees, because you're just going to crank that nerve, you're going to put more pressure on that disc, and it's just not going to go very well. So even if, from my experience, even if they have like 30 degrees, a non-passing test, we're still looking above, because the answers to what you're looking for are more than likely going to be above where they feel the pain and the tension. That's just from experience.
Makes sense.
So after straight leg raise tests, it's quadruped, cuped, lumbar flexion. All right, and we're looking for proper. Can we see in the camera?
No.
Thank you.
Yeah. Okay, that's pretty good, I think.
All right. So quadruped lumbar flexion. We're just trying to create a uniform spinal curve, like so. Most people with restricted lumbar flexion, they'll be flat in their lumbar region, and all of their flexion will come from the thoracic. And there's just like nothing from here down here. You'll see the 2x4. You'll see the straight line, right? And people just won't be able to create that flexion. Again, we can also look into the child's pose, a little more passive than active, and see if the curve emerges through there. You also get a good look at hip flexion angle as well, right? Sometimes the reason they can't flex is actually because of lack of hip flexion, right? In that situation, working on restoring hip flexion may be the answer, right?
Sure.
Have them squat deep a couple times. I've seen that as well. Let's say lumbar. Right. There we go. Cool. So let's say lumbar checks out and it looks good. It's like, okay, why can't this person flex? Then just have them go into quadruped if they run into a restriction there, and there could actually be inability to create hip flexion. So I've seen cases with that. We put them on the TRX, make them do some deep squats, and their flexion reemerges from there too. Bit of a lower percentage case, but definitely have seen it. Definitely one that if you're like, man, it's not. They can't flex. They can't touch their toes. They can't do seated, but their lumbar motion checks out, right? And it's like you're releasing their thoracic spine, you're releasing their lumbar spine, deflection, seated toe touch with the cups. They still aren't getting it, and then you realize they can't like prone rock because they're just stuck. Check hip flexion. That could be the answer. Put them on the TRX, make them sit into their hips, open up that posterior hip capsule, and that sometimes may be the solution.
Interesting.
So, things to think about.
Yeah.
All right.
Yeah. Why would someone lack hip flexion? Certainly, I've heard hip extension, but never hip flexion.
People like hip arthritis or just it's happened.
Okay. It more or less like in an older crowd. Okay.
Or someone that may have like hip impingement, right? FAI.
Okay.
You may have a hip impingement.
Yeah.
Case.
Okay. Yeah, I could buy that one.
Right. And then the reason why they can't do that, all the pressure is building up the front because that posterior hip capsule, the glutes aren't opening up. So just force them to open up into a deep squat. That will usually take care of that.
Makes sense.
All right. So that's assessment. All right. So let's go over interventions next. All right, let's do manual soft tissue.
And then this would obviously kind of just depend on where their issue is stemming from.
Exactly. So let's say if, let's do the most common one, if it's coming from lumbar lack of lumbar flexion, right? What's the star treatment for that?
The cups.
Yeah, cupping. In seated. If can't tolerate.
No, so then this is when we move the cups up a little bit higher to like TL junction.
Yeah, I would say
even up into thoracic.
Depending on, let's write this out. So if can't tolerate sitting.
Oh, I see.
Do cupid.
Okay.
Let's say they're pretty hot sciatica, and just the initiation of sitting is just a no-go. And we'll talk about more about those cases, but typically this is not the first go-to case. If it's more of like a chronic sciatica, not like a hot, severe, like discogenic, like can't bend at all, more chronic stiffness, like people with this like they're in their 80s or late 70s with like 5 years of sciatica, we can do this technique for them pretty confidently that it will help.
Sure.
If it's a 35-year-old guy that just was moving boxes or couches the other day and just can barely move, this is not the time to do that. You want to go extension, McKenzie protocol, stabilize and neutral, get symptoms centralized for about 3 to 4 weeks before we start to even entertain the idea of restoration of flexion. That's going to be really based off of, just case dependent and feel. I would say palpation, right? Of where stickiness slash gristliness of fascia determines location. So when they show restricted lumbar flexion, I've also seen cases where doing cupping on the lumbar doesn't actually like fix it. Like the guy we saw yesterday, it's his thoracic, right?
Yeah.
The knots are higher up in the chain, and it's just flattening everything out. It's weird, but you'll see it when we see it. Where it's like, man, this person just lacks so much thoracic. Their shoulders are all tight, and everything from above is creating tension down below. I would always default to, especially in the beginning when you're just kind of getting a feel of things, I would start higher away from sensitive, irritated tissue first until you really get a good level of comfort of kind of zoning in on the really painful, sensitive spots. I've seen, unfortunately, on more than one occasion, where the person is symptomatic in the lumbar spine, they're really tender and sensitive, and we do the cupping, pulls out a big old welt, it's all bruised up, and they feel great when they leave, but they call the next day and they say, I can't move. And it's like, oh, we did it too soon on irritated areas. And you got to be careful of that. Right? Don't want to do that.
No.
So I'd say starting in the lower thoracic, mid thoracic, if you're not sure, you can never really go wrong. And just retest. If they get back 30% of their flexion based off of that, they'll be happy, you'll be happy. And the risk of you potentially causing irritation is way lower when you're working on the stiff, non-painful, non-irritated tissue. When you release the tension from above, you'll reduce the tension from below, and you'll cause irritated tissues in the lumbar spine to be less irritated. So maybe session 2, 3, and 4, you can then start to get closer into the lumbar spine and start to make some real progress.
Sure.
All right, so that'll be based off of feel of each case, your palpation of where you feel most of the restrictions are, and the cupping will tell you if you're right. If you get a lot of welts in the lumbar spine, you're not getting in the thoracic, then yeah, the issue is going to be more in the lumbar. If you're not getting much in the lumbar, even despite the fact they have no curve, but they're lighting up in the lower, mid, upper thoracic, then that's the cupping will tell you where the restriction actually is.
Sure.
Right, and you'll know just based off of seeing a few hundred of these people, right? You'll just get a feel for where the restrictions are, right? But as I've said, sometimes it's taking me like 10 sessions to figure out that it was coming from their inability to protract scapula. We did the scapula, and then there it goes. They're rounding forward. So I think we'll probably come up with scapular-based like tests, right, at some point, even in the quadruped, just doing a big cat stretch and see how much their scapulas are protracting. You'll find that people that have the issue, they just won't be able to do it. So it means their lats, their scapulas are just stuck, and that's why they can't reach forward, because their arms don't let them reach forward, and that's creating all the tension down below. You free up their shoulders, they'll be able to go, right? Because toe touch is not just the spine and the hamstrings, it has a lot to do with your shoulder scapular movement. So if my scapula is stuck in place, I can't go, which is going to cause me to overexert everything down below, and that's what could cause an injury down this posterior chain. So if people that have like tight shoulders, you free this up, you release the scapula, all of a sudden they're able to reach a lot more without creating any more tension down the chain.
Sure. That
Right.
makes sense.
Right. That's I don't know how many people teach that one, but that's it's a big one when you can find it, and it's very, very effective. All right. That's manual soft tissue. I don't see how, honestly. I don't. I could see it, but I don't see it where chiropractic type of adjustments are going to fix flexion-based cases.
No.
Just don't see it. I don't see I'm always looking for like ways in which I don't know. Help for extension and rotation for sure.
Yeah. I don't really think flexion, and that's
And it's a big issue when people are getting their L5S1s adjusted with a hot disc. It just makes no sense, man.
Yeah, and see the model that I was taught outside of school, of course, especially those first couple of sessions when everything is super hot, can't do anything, adjusting. I mean, especially in those cases where it's like, is adjusting going to help these people? I don't know, 50-50. We're not. Stay far away.
Yeah,
Unless you are 100% certain it's not going to hurt,
Yeah.
stay far away.
Yeah.
Because if adjustments are in a spot where they can help, guess what? They can also hurt.
Yeah.
So, yeah.
All right. So this is manual soft tissue intervention. Cool. Now let's go over corrective exercises, reinforcement. All right, so before we do that test retest, so after you've done the manual treatment, you then want to check to see did straight leg raise improve if it was impaired, or did standing toe touch or sitting toe touch improve? And if you're right, if it is a soft tissue dysfunction along the upper part of the posterior chain, you'll see a dramatic increase in toe touch within, like immediately after you do it. You hit the bullseye, it'll work. It works 96% of the time, right? It's like, that's just how it is.
Sure.
Right? So we're hoping it is in the vicinity of where we think these things are. And if you can find that bullseye, up the cups, do the stretch. For most people, it's going to be a complete game changer for them. Right. So test retest. So do the intervention, see if it's better. If it is better, we go into our corrective exercises. Right. All right. What are the best correctives? Let's say if we determine it's a lumbar, thoracic, like flexion-based problem.
Teach them how to hinge,
Or
the cow.
Yeah, cat.
Yeah.
So revisit. cat stretch. Anyone that's watching this can find the instructions and the link in the description below for this, how to do this stretch. And let's teach them how to create lumbar flexion through the cat stretch.
Sure.
Right. And then hip hinge.
Yeah, cat stretch first, hinge down the line.
Yeah.
Okay.
I don't know. It's been so long since I've ever really taught someone an isolated hamstring stretch. I just haven't done it. You've cleared this up. I haven't seen the need. And just getting them to do a cat stretch, and I'd say getting them into a proper hip hinge is going to take care of any hamstring issues.
Sure. Yeah.
It's not that I ignore the hamstrings. I just think that teaching them a hip hinge is going to be so much more potent and powerful and efficient and an effective way of helping them recreate length in that posterior chain, teaching them posterior weight shift, teaching them neutral spine, and just helping them condition how to create tension, safe, healthy tension along the entire chain with spine in neutral.
Sure.
Right?
Yeah, it's interesting. I've never seen a compelling reason for anyone to stretch their hamstrings either. Literally, yeah. Every single person I've ever met that's like, oh, my hamstrings are tight and I stretch them and it does absolutely nothing.
That's right.
Yeah.
Yeah. And I'd say, again, putting them at hip hinge, you're going to get it there.
Mm-hmm.
And you're going to get so much more body awareness teaching. I value having the ability to create length in your hamstrings, but you're going to get it here.
Yeah.
Instead of like,
mm-hmm.
So that's my whole spiel on that. So hip hinge with dowel for neutral spine. Cues. Right. Is my dowel in here? Right here. So put a stick on the back, 3 points of contact, head, mid-back, butt. And then we're hinging from the hips, trying to maintain all 3 points of contact. All right. People will typically do something like this, right? They'll lose the middle, right? Maintain 3 points of contact and try to shift the hips as far back and up as you can to just condition how to safely recreate length in the chain, right? We get a good image of that?
Yeah. I think you were good.
So from here, you're going to see my butt. From here, like so. That's one if patients have a really hard time understanding concept of neutral spine. Again, neutral spine means your spine is straight. And your spine is straight, it can't get injured. If you keep it straight, it's very, very hard, if not impossible, to injure a spine that's in neutral. It's when it gets out of neutral is when things can rip and tear and break.
Sure.
All right, so education of neutral spine, very important to give people confidence and autonomy that what they're doing is correct. We got to teach it to them if they've never been taught.
Sure. Oh, I see.
This one's also very potent. We good?
Move back a little bit more. Almost. There. Okay.
All right, cool. All right. Once they're able to demonstrate neutral, now we want to teach them how to lift things, right? There's no greater way to develop confidence to be able to lift things than to teach them to lift things. And if it doesn't hurt, they feel good, right? That's why we love teaching this when they're ready for that. So grab onto the weight. I like to have them grab on with a flexed spine first. Show it to them in the mirror so you can teach them this is how not to lift, right? With a flexed and rounded spine, that's how you'll pop a disc. That's how you can strain a muscle. Can just not a good way to lift weights with a spine that's in flexion. I think the Jefferson curl people breaks that belief structure, but those people are not injured and they're training it for resiliency, right? I think that would be I'd love to get people to be able to do that, but that's going to be someone that's a little bit of an outlier where we're going to be actually be having them do that, right?
Yeah.
But I see the value in having tons of resiliency with loaded flexion, right? And these people are clearly demonstrating that if you do it well, it's just fine.
Oh yeah, 100%.
Most of our population, it's not fine for them to do that.
Yeah.
But we'll see. We'll see.
I mean, at least not right now.
I'm open-minded.
Yeah.
Right. I'm open-minded to it.
Again, everyone's got to bend down and pick up a receipt. And honestly, good luck doing that with a straight back.
Right.
Yeah, you have to have some flexion in there.
Right. So I think it would be teach the hinge in neutral, have them at least be able to create flexion without pain, right? That should just spontaneously reemerge. And then we can have discussions about when to load a flexed spine and when that is appropriate and indicated, right? So we'll see. We'll have discussions about that. I'm open-minded to learning for what person, when, and where.
Sure.
Right? Stu McGill would not agree.
Yeah.
All right. Start in flexion, and we teach them create neutral. Right. Cues to abduct the hips by pushing the knees out to really wind up the external rotators and lock in the glutes. And from there, we're trying to... Earthquake?
Your phone's shaking.
Earthquake. Earthquake.
Oh, shit.
You're going to get more? You're going to get more? All right. Knees out, back straight, hips back, and drive them up towards the ceiling. Breathe in, exhale, push deeper. Let go, stand up, right? And then you retest the toe touch. That'll teach the posterior weight shift, just teach them the motor control of how to actually do the hinge. And we'll see people palming the floor after just a couple of those. Any more? You feel it? Earthquake?
I don't think so. I think everything stopped.
First one you felt?
Second.
Second.
Dude, it was 2 a.m. back in Montana. I was sleeping at my parents' house. The room starts shaking. All my clothes start going everywhere. Scared shitless.
Yeah. I didn't like hearing the crackling.
Yeah, that's what scared me.
I was like, shit.
Yeah.
But I think we're good. Felt that one.
Yeah. Does that mean it was registered on the scale, like a 2 or a 3?
Yeah.
Let's see. I'm curious now.
Nope. A little more. Saw the plant shaking.
Oh, it's definitely still shaking. says 13 hours ago there was a 1.6 in San Ramon. 2.4 East Foothills, California.
Just now?
It said today. I mean, it's still shaking. I feel it. I don't like that. I think we might be good.
All right, cool.
Hopefully.
All right, so after we do the static hold, teaching posterior weight shift, the teaching point I usually use is, all right, now that we've lengthened the chain, we want to make sure that this chain is strong, resilient, and robust. And think of it, the movement, the hip hinge, like pretend this is like a bow and arrow. We're trying to wind this arrow back as far as possible. The more tension you create on the arrow or on the bowstring, the further the arrow will go. So we're teaching people the point at which they're hinging from the hips is the point at which you're creating tension through the bowstring. So the further those hips go back and up, the more passive tension you're going to get, and that's what's going to deliver a nice hip hinge on the continuum of hinging.
Sure.
All right. We need to get a little more vertical power for an actual deadlift. Yeah, we want to sit down and get the quads involved. But for purposes of conditioning of the posterior chain, I think an RDL with slightly bent knees is my, as you've seen me do, my preferred way of just hammering the hinge.
Yeah.
It's been effective. So that's the my thought process behind that.
Makes sense.
I think we're going for power. Yeah, let's have it squat a little more, get the quads to help out. Why not?
Sure.
Right? So it just depends on where they're at in the rehab process, and are we just training for rebuilding the resiliency of the posterior chain, or are we starting to integrate power and actually want to get more out of that? And that's going to be dependent on what our goals are.
Sure.
All right, so we clear on that?
Yeah, 100%.
All right, so we have the next one would be lowering the kettlebell down a lower or even towards the floor. Same thing. And from there, we'll actually teach the lift. Chest out, back straight, knees out, chest up, and bring the hips up as you come down. Nice, flat, neutral spine. All right, good lat activation. And just really hinging through those hips. Nice stretch and strengthening of the posterior chain all at once. All right, and then end stage advancements. We'll go into single leg, RDL.
And then do you prefer contralaterally loaded with this?
I like both.
That's fair.
I usually don't do ipsilateral, but you could for more advanced people.
No, that's fair. It seems when you're talking single leg RDL, anything contralaterally loaded is like most bang for your buck from what I've seen. Plus, one of the other things I've seen, you know how most people kind of lack hip internal rotation.
Yep.
You get that contralateral rotation, then we're training a little bit of that hip IR too.
Yep.
Kind of like a win-win.
Yep. And then kettlebell swing. It's the end staple. So that's the full progression from subjective to diagnosis, assessment, manual treatment, your base, minimal, or beginner level correctives into the full progression.
Nice.
How to fix it. It's flexion. It's the program. All right, questions?
Nope.
Cool. You can hit pause.
Okay.